Hello, everyone, and welcome. Thank you for joining us today for our program on the Meaningful Use Stage 2 and Standards and Certification Criteria Final Rules. This is Kate Berry, CEO of National eHealth Collaborative. NEHC is a public-private partnership with a mission to advance nationwide health information exchange to improve health and health care. Today we are very pleased to once again welcome Rob Anthony from CMS and Steve Posnack from ONC. In just a few moments I will introduce them, although many of you have probably heard from them before since they are the foremost experts on these regulations. Next slide, please. Recently, NEHC launched a membership program. The benefits are highlighted here, and they include visibility and recognition for being part of an influential health IT organization, preferential participation in leadership of strategic work groups, discounted participation in our programs, unique networking opportunities with industry leaders, and weekly summaries of health IT media stories and synthesis of critical information. For more details, please visit our website. Next slide, please. This slide just shows our current members, and we're very pleased to have diverse and leading organizations joining NEHC. We've got health systems, patient-focused organizations, health information exchanges, technology companies, state agencies, public health agencies, quality-focused organizations, health IT startups, and many more. We're really grateful for our members' leadership and support of NEHC, and we encourage all interested stakeholders to join our membership program. Next slide, please. I'd also just like to call your attention to a conference that we'll be convening with Infocom in DC on late November, the 27th and 28th, which is the Technology Crossroads Conference. This conference will explore the intersections between audio-visual technologies and health IT and health information exchange. We have some really outstanding speakers and panelists lined up, and there are going to be some thought-provoking discussions on how AV technologies are being used in healthcare, and indeed in combination with health IT can lead to breakthroughs in healthcare, such as telemedicine, remote monitoring, patient engagement, innovations, and more. So as part of this conference, there's going to be a special track dedicated to health information exchange, and we'll be presenting and discussing some of the initial outcomes of the NEHC Health Information Exchange Learning Network work groups on topics such as health information exchange sustainability, HIE functions to support new payment and delivery models, and much more. You can find more information on this conference on our website. Next slide, please. Given the high level of interest in the final rules that we're going to be discussing today, we are going to repeat this program again on Thursday, August 30th, just 2 days from now, at noon Eastern. And for that program, we'll have Travis Broom from CMS and Steve Posnack, once again from ONC, to discuss the Meaningful Use Stage 2 and Certification final rules. Next week, right after Labor Day, on September 5th, from 2:30 to 4 Eastern, we'll have Gwen Darlinger presenting on the popular Health Information Technology Orientation Program. This program will provide an overview of the healthcare industry landscape and trends, including both government and private sector initiatives. And then on September 11th at 1 o'clock Eastern, we will kick off a new series on health information technology in rural and underserved communities with the rural health IT landscape. Our speakers for this program will be Earl Rugg from Rural Health IT Corporation and Chantal Warzala with the American Hospital Association. And then on September 19th, from 1 o'clock to 2:30 Eastern, we'll welcome Paul Touton from ONC, Dr. Bill Braithwaite from Anacam, Michael Nelson with Equifax, and Drew McNichol of HealthyLink to discuss increased medical record security for both physician and patient access. Next slide, please. The slides from today's session are available at the link shown on the slide, so www.nationalehealth.org/final rules. Next slide. And during the program today, please do enter your questions as they come to mind, and we will have time for Q&A later in the program. So now I'm very pleased to introduce our speakers today. Rob Anthony is a health insurance specialist in the Office of eHealth Standards and Services at CMS, and he works primarily on meaningful use policy for the Medicare and Medicaid EHR incentive programs. And we have Steve Posnack, who is the Director of the Federal Policy Division within ONC's Office of Policy and Planning. Steve is responsible for ONC's legislative and regulatory affairs, including leading ONC's review of legislation and regulations, briefing ONC leadership on legislative and regulatory issues, and the ONC's regulation development efforts. So Rob's going to lead off, and then we'll take a few questions for him, and then we'll have Steve present and take additional questions at that time. So Rob, I'd like to turn the program over to you at this time.
Thank you. Thank you, everybody, for attending this afternoon, and thank you to NeHC for hosting this. This is going to be a repeat of the Stage 2 overview that we did on Friday, so if you're looking for a deeper dive on things, this is not really what's going to happen. We're going to talk about the same type of material. I do want to let people know that I'm going to talk pretty quickly here because I'm going to try to do it even faster than I did on Friday so that we can give Steve Posnack from ONC a little bit more time to talk about certification. However, there is some information that is available on our website. If you go to www.cms.gov/EHR incentive programs, there is a Stage 2 tab, and we have tip sheets available that give an overview of Stage 2, that talk about changes to Stage 1, that talk about payment adjustments for both EPs and for hospitals, and that talk about the 2014 clinical quality measures. So please feel free to visit our website and get a little bit more in-depth information. Next slide. Some of what we're going to talk about today are exactly what those tip sheets are covering. So changes to Stage 1 of meaningful use that are in this rule, obviously the Stage 2 meaningful use requirements, new clinical quality measures, structures and reporting mechanisms, payment adjustments and hardship exceptions that are provided in this rule, and some of the Medicaid program changes that were provided as well. Next slide. Farzad talked a little bit last time. Farzad Mostashari, the National Coordinator of Health IT, talked a little bit about what we were doing with Stage 2 and what Stage 2 means for providers. Obviously, it does mean some new criteria, some higher benchmarks for people. We did aim to include objectives that really focused on improving patient care through better clinical decision support, care coordination, and patient engagement, and I'll highlight some of those. And obviously all of this is aiming towards that goal that we have of reducing the cost of health care, saving time for providers, and saving lives. Next slide. So the first thing I want to talk about is eligibility. If we go to the next slide, we often get the question about who can be eligible for this program. During the public comment period on the Stage 2 notice of proposed rulemaking, we had a number of people who specifically requested that we make other provider types or other facilities eligible to receive EHR incentive payments. The issue for us is that the eligibility is really determined by Congress, by what was put into the HITECH Act. There haven't been any changes to the HITECH Act, so we are not able to expand eligibility. So you're not really going to see that in the Stage 2 rule. The only thing that we could look at were the things that were specifically under our regulatory purview. And to that end, next slide, we did take a look at the hospital-based EP definition because we got feedback from some hospital-based EPs that there are some EPs who are working within a hospital who fall under that definition of hospital-based, which is that more than 90% of their covered professional services are in an inpatient or emergency department, but they actually operate on a completely different system than the hospital does. Neonatologists popped up in this discussion, as well as some others. So we did make an exception so that people could, through an application process, apply for redetermination of their hospital-based status. They'd have to be able to show that they specifically fund the acquisition, implementation, and maintenance of certified EHR, and that includes everything that kind of goes with it for support, hardware, interfaces, everything else, without receiving reimbursement from the hospital or CA, that they are using that system in lieu of using the hospital's certified EHR. And if all of those criteria are met, then that EP could potentially be determined to be non-hospital based and in meeting meaningful use receive an incentive payment. Next slide. I want to do a brief overview of what actual meaningful use is, the Stage 2 meaningful use requirements. If we move to the next slide, This is an illustration of the timeline of meaningful use. One of the things that we talked about in this reg is the Stage 2 timeline. We did introduce in the NPRM an extra year for folks who had attested in 2011 to be able to stay with Stage 1 requirements for an extra year, effectively delaying Stage 2's first onset until 2014 at the earliest. This is an illustration of what that would look like for Medicare EPs. For the most part, whenever you begin meaningful use, you're always going to begin at Stage 1, and for the most part, everybody is going to do 2 years at Stage 1, 2 years at Stage 2, and then move on to Stage 3. For those in 11 who started in 11, you will get that extra year, as you can see by the chart, at Stage 1. Medicaid EPs would work the same way, although since they do not have to participate consecutively years, they can actually come back in non-consecutive. They could come in 2011, come back in 2014, but they would work the same way where they do 2 years at Stage 1, 2 years at Stage 2, and then move on to Stage 3. Next slide. Hospitals obviously are working the same way. They just work on the fiscal year instead of the calendar year. They come in and they do 2 years at Stage 1, 2 years at Stage 2, and then move on. The early adopters in 11 will be able to get an extra year at 2013. Normally the way that this is going to work is your first year of Stage 1 is going to be a 90-day reporting period, and then every subsequent year will be a full year reporting period, so a full calendar year for EPs or a full fiscal year for eligible hospitals. Because everybody is going to be upgrading to 2014 certified EHR technology in 2014, the old technology, the technology that you currently have in place, its certification won't continue into 2014, so you will either have to upgrade, or if you're newly participating in the program, you'll have to get the new 2014 technology, and we want to be sure that there's ample time for vendors to develop that technology and for all providers to get that in place. We are providing a one-time only in 2014 for all providers, regardless of your stage of meaningful use, whether you are a Stage 1 or Stage 2. There's going to be a 3-month reporting period that is tied to the quarters for Medicare, or a 90-day reporting period that can happen at any point within the calendar year for Medicaid EPs. But we are providing that special 3-month or 90-day in 2014 only to allow everybody to be able to get on board. Next slide. As you see, this is an overview of moving from Stage 1 to Stage 2, what it looks like. We did retain the core and menu structure as we had indicated. We did try to keep the total number of objectives the same, so 20 and 19 for EPs and or eligible hospitals respectively. We did this by, in some cases, eliminating some objective. You'll see that the Stage 1 objective for testing the exchange of key clinical information has been eliminated in favor of a actual use case of transitions of care in Stage 2. You'll also see that a number of objectives were combined when they centered around similar principles. So, for example, the Stage 1 objectives for implementing a clinical decision support rule and implementing drug-drug and drug allergy interaction checks for the reporting period all center around clinical decision support. We put those in a single objective with 2 measures that are clinical decision support and the drug-drug, drug allergy interaction checks. In some cases, we actually subsumed some other objectives, such as recording problem list, medication list, or medication allergy list under other objectives. In other words, you still need to maintain a problem list, med list, or med allergy list in order to achieve certain objectives, such as the summary of care after a transition of care, but we aren't specifically measuring problem list and medication allergy list. Next slide. Some of the things that changed and didn't change, one of the things that is changing is in regards to meaningful use in general is the idea of excluding menu set objectives. Although there are still exclusions available for menu objectives, you cannot claim a menu set exclusion unless you are able to exclude from all of the other menu objectives. Effectively, this means that you cannot select a menu objective and then exclude from it if you are able to report on other menu objectives. So if there are other menu objectives that you could select and report on. That is true for Stage 2 and for Stage 1. One of the things that you won't see, or one of the things that is not changing, is we are maintaining that threshold for locations with certified EHR technology. You still, as an EP, have to have at least 50% of your patient encounters at locations that are equipped with certified EHR technology. And then, as you'll see on that third bullet at the bottom, then you can base your denominators for certain objectives on just those outpatient locations. You do not have to base the denominators on all patients seen during the reporting period, just all patients seen at the locations equipped with certified EHR technology. And of course, the thing that has not changed is what we consider compliance for the objective, what we consider meaningful use, is meeting the measure of that objective. So meeting that percentage threshold, or being able to answer yes to the yes-no questions, is meeting that particular objective. Next slide. We did mention that 2014 there are going to be all new certified EHRs, and Steve is going to talk a little bit more about what that entails. But that does mean that, and we keep getting this question, your certification for your current certification will end, and you will have to upgrade to 2014 technology. There will not be Stage 1 and Stage 2 technology. The 2014 technology will include the ability to do Stage 1, Stage 2, and the clinical quality measure reporting. And we already mentioned the reporting period has been reduced in 2014 only to 3 months to allow everybody time to get that new technology on board. Next slide. One of the other things that we talked about in this was batch reporting. We are going to allow for batch reporting, and essentially this means that groups would be allowed to submit attestation information for a number of EPs in a single file that you would then upload to our attestation system. This would be in lieu of having to have somebody or the EP go in individually for every provider and enter numerator and denominator information. We'll be releasing details about what that attestation file, what format it will take, and how to do the upload later. Obviously, that system isn't in place yet, but it will be in place for 2014. We do think this is going to be a real time saver for a lot of practices and should reduce the burden around reporting. Next slide. These are the core objectives. You can see over the next several slides the core and menu objectives for eligible professionals, the core and menu objectives for eligible hospitals. I'm not going to go through each of these individually. I just want to call attention to a couple of things that you are going to see here. One is that many of these core objectives are going to look similar because they are the core and menu objectives from Stage 1. We moved the majority of the menu objectives, as we had indicated we would, from Stage 1 into the core for Stage 2, and most of the menu objectives in Stage 2 are new. We did bold the areas here where something changed from Stage 1, so you will see that for e-prescribing, it's e-prescribing for more than 50% of prescriptions. That is up from the original for 30% under the Stage 1 requirements. The record demographics has moved from more than 50% to more than 80%. You'll see that throughout as we go through this. Next slide. One of the things that is different for both EPs and hospitals is that we have replaced some of the previous objectives in Stage 1 that were around providing an electronic copy of health information to patients with patient access, and that's providing online access to view, download, and transmit their health information for more than half of patients. And there is a measure here that is a little bit different than what you would encounter in Stage 1, that more than 5% of patients actually have to access that. We did solicit comments on this, and we did hear varying opinions about this. We know that there were concerns about providers not being able to meet meaningful use because of patient inaction, but we do believe that providers are in an important and unique position to encourage patients to take an active part in their health care and accessing those records. So we did provide this low percentage. We did lower it in reaction to comments from providers, and we think that this should be achievable for everybody. The other thing that you're going to see here that is different is that, that is similar, is on number 13, secure messaging. This is a new objective that we placed in the core because we think that it has such a potential to actually impact patient care. And this, again, requires patient action. It's still a low percentage, but it requires that more than 5% of patients actually send secure messages to their EP. That messaging technology will be available as a part of certified EHR technology. The other big change, and this is true for both EPs and hospitals, is in the summary of care. We moved from to an actual case use of summary of care documents. So in this case, increasing that percentage of summary of care documents for more than 50% of the transitions of care and referrals. There is an electronic component where we require that 10% of those have to be sent electronically. And while we had initially, in our Stage 2 proposed rule, proposed the notion that the 10% had to be sent to a provider who was using a different EHR vendor, we did get a lot of feedback to that, that it could be very difficult, especially in areas where there are high penetrations of certain EHRs. We did get some feedback that it could potentially change referral patterns, and then there was some concern about how this could actually be measured ahead of time. How would you know who had what ahead of time? So we've actually separated these out to a 10% measure that the summary of care documents have to be sent electronically, and then a second measure that at least one of those that are sent electronically have to be sent to a recipient with a different EHR vendor, or in the case that you may not have access to a different EHR vendor to send to somebody, you can successfully test with a designated CMS test EHR. So CMS, ONC, and NIST will be developing a product that providers can exchange with in order to actually meet this objective. And we feel that this preserves the actual ability to exchange documents across vendor boundaries, which is an important part of making that information available in all areas. Next slide. Most of these will be new. The one menu objective that is a carryover for EPs from Stage 2 is syndromic surveillance, and that's simply because we didn't feel that there were enough syndromic surveillance databases available for EPs in order to make this a required core objective. But you will see that imaging results, family history, are new. Progress notes we originally did not include as one of the proposed objectives, but we received a great deal of comments that people felt that it was an important part. So entering an electronic progress note that is searchable text for more than 30% of unique patients is a menu objective. Cancer and specialized registry information, submission to these 4 and 5, particularly trying to make this available for specialists, because we had gotten a lot of feedback that there were not too many objectives that were centered specifically on specialists. Again, EPs would select 3 out of the 6 of these menu objectives. Next slide. Hospital objectives, of course, you're going to see much of this is very similar. I want to call attention to a couple of things. One is here on this slide at the bottom, number 8, EMAR. This is electronic medication administration. This is tracking of medications through the hospital, through the EHR. The requirement here is that it implemented and used for more than 10% of medication orders. Again, we felt that this is a new one to go in the core, and it could have such an important effect on patient safety that it warranted being in the core. Next slide. Again, you'll see the patient access, the view online, download, and transmit, with 5% of patients accessing that, an important part for hospitals. And here again, number 12, summary of care, the same 10% electronic measure, and at least one of those sent to a recipient with a different vendor or to the test certified EHR, or the test CMS EHR. Next slide. The menu objectives are also similar. You see imaging results, family history, progress notes. We do have an e-prescribing menu objective for hospitals, one for providing structured electronic lab results to EPs. We did hold advanced directives from the Stage 1 menu in the Stage 2 menu, because there are some differing laws and regulations according to state and localities about how advanced directives can be acted on, until we get some clarity about how that works across all locations. We didn't want to place that in the core. Next slide. So again, we talked about patient engagement being a major focus of stage 2, and that's where you see the requirement of the 5% of patients sending secure messages to their EP, 5% of patients actually accessing their health information online from an EP or from a hospital. There are exclusions available for these for based on broadband availability in the provider's county, so we do recognize that that would be a potentially insurmountable hurdle, but we do feel that the 5% is a low enough threshold that, that all providers should be able to meet that. Next slide. And then obviously the other focus of stage 2 is really on electronic information exchange and actual use cases rather than the test cases that were, or testing that was really the part of stage 1. So providing that summary of care record for more than 50% of transitions of care, 10% of those sent electronically, and at least once sent to a different EHR vendor. Next slide. There are some changes to stage 1 that are provided within this rule as well. One of the changes is an optional computerized provider order entry denominator. The current denominator is unique patients with at least one medication in their medication list, and this caused a great deal of confusion about whether the unique patient had to be seen during the EHR, or I'm sorry, the medication had to be prescribed during the EHR reporting period, whether the EP had to be the person doing the prescribing. None of those things are true, but it certainly has caused some confusion with folks. So we are providing an option for stage 1 of the denominator of the number of orders during the number of medication orders during the EHR reporting period. So that should be a little bit more streamlined for people. Next slide. For vital signs, we are changing both age limits and exclusions for stage 1. These will be optional changes in 2013, but they will be required starting in 2014 when the new certified EHR technology comes out. We are changing the age limit to be more in line with the APA's recommendations, moving from an age 2 for height, weight, and blood pressure to age 3 for blood pressure and no age limit on height and weight. We did get a lot of feedback about the exclusion, which currently is that all 3 elements have to be not relevant to the scope of practice, but we are now separating that out. So if either all 3 elements are not relevant, you could exclude all 3. If blood pressure specifically is not relevant, you could exclude blood pressure. If height and weight both are not relevant, you could exclude height and weight. So essentially breaks up, separates those exclusions. Next slide. As I mentioned before, we are eliminating the test of electronic transmission of key clinical information. That will be effective starting in 2013. Next slide. And in order to coincide with the upgrade to 2014 certified EHR, which will have that stage 2 ability, that objective to view online, download, and transmit health information, we are replacing those objectives in 2014 that are currently in stage 1 of providing patients with an e-copy of their health information upon request. There is an EP menu objective for providing electronic access to health information. We will be changing that objective to providing patients the ability to view online, download, and transmit their health information, essentially the same functionality that will already be built in for that stage 2 objective. The only difference is that in the stage 1 objective, there isn't a requirement that 5% of patients actually access that information. That patient requirement, that patient action requirement will not take place until stage 2. Next slide. And then finally, we are adding the addition of except where prohibited to all of the public health reporting objectives. It's really for clarity purposes. There are some providers who got caught in a little bit of a catch-22 where state or local regulations prohibit them from reporting on certain of these objectives, and how yet we were requiring as part of meaningful use. We didn't want anybody to be caught in that catch-22, so we're adding that language. Next slide. Very quickly on the clinical quality measures, I'm going to go through some of what has changed for 2014. And I want to stress that this is a pretty high-level overview, but if you want to visit our website, again, there is a tip sheet that outlines all of this in a little bit more detail, specifically about 2014. The one thing that I want to draw attention to before we even start here is that what is going to change is clinical quality measure reporting in 2014. So Don't necessarily think of it as stage 1 clinical quality measure reporting and stage 2 clinical quality measure reporting. Just as there aren't stage 1 and stage 2 EHR certification, there isn't stage 1 and stage 2 CQMs. There are CQMs that are reported under the 2011 certification criteria, and then there will be CQMs that everybody reports the same way beginning in 2014 with the new 2014 certified EHR. So regardless whether you're at stage 1 or stage 2, everybody is going to report clinical quality measures the same way. The other thing that we have done is we've removed the reporting of clinical quality measures as a core objective, essentially because it was redundant. We were asking people, do they intend to report on these? And then we were actually asking them to report on them. We'll obviously know if you're reporting when you report. However, just because we've removed that as a core objective, it doesn't mean that CQMs are not required. They are still required in order to demonstrate meaningful use and receive an incentive payment or avoid the payment adjustments. Really what we have aimed for here with CQMs is to get to reporting, streamlining reporting across several different CMS reporting programs in order to reduce that provider burden. We did hear a lot of feedback from people who were tired of reporting the same or even sometimes different things to multiple different programs. It took a great deal of time, and how could we make that more efficient for people? So next slide. So there's really been a commitment on CMS's part to align quality measure reporting across a number of different programs. On the hospital side, it's across EHR and the hospital inpatient quality reporting program. On the EP side, certainly across the physician quality reporting system, CHIPRA, the ACO programs, the shared savings programs. We've tried to align both measure sets where that's possible. Where it's not possible, we've done some deeming. We have tried to align some reporting methods, and you'll see what some of those are in just a moment. But we are trying to get towards that goal of reporting the same thing, reporting once. Next slide. And as I mentioned, one of the things that we are trying to do, and you'll see this especially on the EP side, is align the measure sets. So the PQRS measures will be similar to or the same as the EHR incentive measures, and you'll report through similar methods. Next slide. Again, trying to lower provider burden here and support that goal of all of the CMS quality measure programs, but ultimately really the entire idea behind these clinical quality measures and reporting is trying to get to that overall goal that you see with meaningful use, which is better quality care, better outcomes, and reduced costs. Next slide. One of the things that we do introduce is that providers have to select CQMs in 2014 across our Health and Human Services National Quality Strategy domains. These are sort of the high-level priorities for the Department of Health and Human Services that CMS and ONC both fall under: patient and family engagement, patient safety, care coordination, public health, efficient healthcare resources, and clinical effectiveness. You'll notice that, of course, many of the meaningful use functional objectives fall under these same quality strategy domains. That's sort of the priority with all HHS programs. But one of the explicit requirements for reporting CQMs for both EPs and hospitals will be that those CQMs have to be selected from at least 3 or represent 3 of these 6 national quality strategy domains. We will release on our website, we don't have it available now, but we will release in the future on our website the finalized clinical quality measures that both EPs and hospitals have to report on, and in there we will indicate which of the national quality strategy domains each of those clinical quality measures falls under, so you'll know which of those you can choose from. Next slide. And this is just what I covered. We will also post a recommended core set of clinical quality measures for eligible professionals. There's both a pediatric and an adult core set of 9 that really focus on high priority health conditions, things like blood pressure management. You'll see that on our website in the future too. Next slide. So as I said, beginning in 2014, everybody's going to report CQMs in the same way. And everybody who is beyond their 2nd year of demonstrating meaningful use is going to electronically report. The Medicare EPs will electronically report your CQM data to CMS. Medicaid providers would electronically report their CQM data to their state, obviously. Next slide. This is an overview of what the current CQMs look like prior to 2014 and what they will look like in 2014. So right now, EPs are reporting on 3 core, 3 alternate core, and 3 menu. Hospitals on 15 set. In 2014 and beyond, EPs will report on a set of 9. They will choose 3 of those from the National Quality Strategy domains, and as I said, there's going to be core CQMs for the adult and pediatric population. Eligible hospitals will select 16 out of 29 measures. Next slide. There will be various methods to report. If you're in your first year of demonstrating meaningful use, you are going to actually continue to submit your information on CQMs the same way that you currently submit your CQMs. That is through attestation, through our website. Beyond that, people will report electronically. EPs will have a variety of options. There will be the ability to submit individually through the Physician Quality Reporting System, EHR reporting option, or to report as a group under the PQRS reporting option. They could also report as a group as part of a Pioneer ACO or Medicare Shared Savings Program, and if they satisfy those reporting requirements, they will be deemed to have met the EHR Incentive Program reporting requirements. There will also be an aggregate method of reporting, so you would be able to submit all of those 9 through a CMS-designated system that would come out as well. Next slide. Eligible hospitals will have something similar. In their first year, they will attest through, or they will submit their CQMs through attestation. They will also be able to submit something either through something similar to what we have now under the Medicare Incentive Program electronic reporting pilot for hospitals, or also an aggregate submission through a CMS-designated system that we'll have available in the future. Next slide. These just outline the reporting periods. The reporting periods don't actually change in your first year of meaningful use. You'll do 90 consecutive days. After that, you'll do a full calendar year, hospitals obviously on the fiscal year, and this just outlines the submission period for those. Next slide. In 2014, obviously, your CQM period would work the same way that your meaningful use period was. You would, on the Medicare side, it would be aligned by quarter. Obviously, on the Medicaid side, it doesn't have to be aligned, but this just indicates what the quarter alignment would be for that optional reporting period in 2014. Next slide. And as I said, there's going to be a core CQM list that is posted for EPs that focus on those conditions that contribute to the highest morbidity and mortality for beneficiaries, that represent the national public health priorities, things that are common to health disparities. Next slide. And those things that disproportionately drive costs. Next slide. However, in 2013, the CQM reporting is going to remain the same as it currently is now. There'll be an update of electronic specifications for CQMs on the website. There will continue to be the 2 reporting methods available. We currently have them now. You can either attest through the website, or you can take part in one of the e-reporting pilots, the PQRS reporting pilot for EPs or the e-reporting pilot for eligible hospitals. Medicaid providers continue to do their state-based attestation submissions. Next slide. I'm going to go very, very quickly through payment adjustments because it boils down to a couple of very simple things. There are a number of charts that give you a look back at what year we look back and talk about the particular percentages. There is a separate tip sheet on this that you can reference if you would like. Next slide. The important part here is that we essentially we're mandated to begin applying these in 2015. It's part of the High-Tech Act. The High-Tech Act specifies that to avoid that payment adjustment for a Medicare EP or a Medicare hospital, that you have to be a meaningful user. If you are participating in the Medicaid program because you are eligible for both programs, it is important to know that Adopt, Implement, Upgrade payment does not qualify as meaningful use. You have to actually be a meaningful user. And you can demonstrate that to either Medicare or Medicaid, but you have to be a meaningful user to avoid it. These, again, only apply on the Medicare side, but you could be eligible for both. Next slide. For EPs, the payment adjustments are mandated. They essentially are 1% a year until 2018, at which point we take a look at how many EPs are meaningful users. Depending on the number who are meaningful users, that will either stay constant, as you see below, or it will continue until you reach a point of a maximum of 5% payment adjustment. Next slide. We essentially do a prospective reporting period for determining the payment adjustment. This is because we have to begin for EPs and eligible hospitals on the first day of the calendar or fiscal year to assess that payment adjustment. And so we are basically looking at the last possible moment of a EHR reporting period. So if you demonstrated meaningful use in 2011 or 2012, we're going to look back to see if you have an EHR reporting period, either your full year in 2013 or that 3-month period in 2014 for 2016. We'll be looking back to essentially 2 years prior. We often get the question of, to avoid those payment adjustments, do I just have to demonstrate meaningful use once? But as you can see from this chart, we look back each year to a different period, so you have to continue to demonstrate meaningful use every year to avoid payment adjustments in subsequent years. Next slide. If you would demonstrate meaningful use for the first time in 2013, we're just going to look in 2013 for that 90-day reporting period, and then we'll look in subsequent years for the full year reporting period. Next slide. And if 2014 is the first year that you do meaningful use, then we'll just look for that 90-day period in 2014. The issue that we have is that we need time to process, which means that we have to have your attestation no later than October 1st. So you have to begin your 90-day EHR reporting period no later than July 1st. Next slide. If you are, I said this before, if you're eligible for both programs, you're going to have to demonstrate meaningful use in one of them in order to avoid a payment adjustment. Next slide. This is the percentage increase to the inpatient prospective payment system payment rate that a hospital receives. It is, again, mandated in law, and it just gives you an indication of how that math works. If we go to the next slide, you will see that payment or the adjustment period that we look at works very similar to the way EPs do. It just works on the fiscal year. So if you attest in 11 or 12 as a hospital, we will look for a full year period in 2013 or 2014 for 2016. If you are demonstrating meaningful use for the first time in 2013, we just look for that 90-day reporting period in 2013 and then a full year in subsequent years. Next slide. If you are demonstrating again for the first time in 2014, we look in 2014 for a 90-day reporting period, but we need that time to process. So the hospitals have to submit no later than July 1st, 2014, which means they have to begin their 90-day reporting period no later than April 1st. Next slide. COS work a little bit differently. It is a reduction of your percentage of reasonable cost, again, mandated in law. You can take a look at this on our tip sheet. Next slide. And they work a little bit differently in the payment period because they submit a reasonable cost report, and then we look at the reasonable cost report, which is submitted after the actual year. So for COS, we can actually look at the actual reporting period year, which is the indication of what you see here. Next slide. There are hardship exceptions that are available. I'm actually going to focus on just this slide. The first 3 infrastructure, new provider, and unforeseen circumstances are common across all providers, EPs, eligible hospitals, and critical access hospitals. So insufficient internet access or insurmountable barriers to it, newly practicing EPs, new hospitals, or new COS can get a time-limited exception, unforeseen circumstances such as a natural disaster. All of these you can apply for. It will be an application process. 4 and 5 are specific to EPs. For EPs that can demonstrate that they lack face-to-face or telemedicine interaction with patients, or they lack a follow-up need with patients, they can apply for a hardship exception. We particularly call out radiology, anesthesiology, and pathology as 3 specialties that we know fall into this category and who would not have to go through the application process. They simply have to have their specialty designated correctly in PACOS. I have received some questions about which PACOS codes specifically, and we will be releasing some guidance about this fairly soon. It's just we haven't had a chance to pull that together yet. There's also for a fifth category for EPs who practice at multiple locations that demonstrate that they lack control over availability of certified EHR for more than 50% of their patient encounters. Next slide. Again, talking about anesthesia, radiology, or pathology, but as of July 1st of the preceding payment year, you're going to receive that hardship exception. Next slide. The next two just, or the next one just covers the same exceptions for hospitals and CAS, as I mentioned before. Next slide. For everybody else, it will be an application process. There are deadlines for it, April 1st for hospital, July 1st for the year before the payment year. We don't have that application process in place yet, obviously, because we're not close to actually assigning payment adjustments, but we will post some information about how to apply for those on our website in the future. Next slide. I'm going to very briefly talk about some Medicaid-specific changes. Next slide. One of the things that was introduced here was an expansion of the definition of patient encounters. This adds to the calculation of patient volume. It essentially provides flexibility as to who can be included in there. It includes some of those in Medicaid expansion encounters and those with zero pay claims. It also adds some flexibility in that look-back period, all of which we think will allow more EPs to be able to qualify on the Medicaid side. You can take a look on our website for some links to some FAQs that will tell you a little bit more in depth about those different patient volume calculations. Next slide. I'm not going to go through each of these, but you can also take a look at some of these patient volume calculations for Medicaid under these slides. I think that the FAQs will supplement some of this for you. Next slide. Again, we'll keep going through these. Next slide. And we'll go to the next until we get to this one. The other thing that is made available here, or that we did in the Stage 2 rule, is we made 12 children's hospitals that were sort of inadvertently prevented from participating as meaningful users because they didn't have a CMS certification number, because they didn't bill Medicare. We've made them eligible to participate in the program. Next slide. And there are some changes to hospital incentive calculations as well. Again, there's specifically an FAQ that deals with this, but essentially changes the period for the hospital incentive calculation in some cases, and what fiscal year can be used for those. So do take a look at that FAQ on our website. Next slide. This is just a link to our web page. Again, you'll find tip sheets there and links to both the CMS and ONC rules. I would encourage you that to be your first stop, and you will see that over the coming months we're going to develop some additional educational resources. So I realize that was a little bit long, but hopefully that gives you a pretty good overview of what you will see in the Stage 2 rule.
Thank you, Rob. This is Kate. That was fantastic. You really covered a lot incredibly efficiently. We'd like to just go ahead, and we have a lot of questions coming in, so I'm just going to start rolling with a few questions for you, Rob. And I realize, you know, there's only so much you can probably really address, but perhaps in some cases you can forward them to certain resources. And we are posting in the chat the tip sheets and stuff like that. So here's one for you, Rob. Regarding, these are acronyms, I don't even know them all, regarding eligible provider CPOE measure. For Stage 2, the final rule clarifies that CMAs can enter orders as appropriate. Does that clarification apply retroactively for Stage 1 EP CPOE meaningful use measure?
You know, that's a good question. We didn't specifically address it. If we're going to release that type of guidance, we're going to have to release that officially. So that's one that I'm going to have to tell you we'll have to take back, and you would want to look for an FAQ for us about that.
Can you comment at all about how the final rule addresses mobile app technology?
Steve may be able to talk a little bit more about that from the ONC perspective when he discusses things, because that probably has more to do with the technology side of things. From our consideration for the CMS meaningful use side, we set more of the use of technology or goals that have to be accomplished with the technology. I do know for a fact that there are a number of providers who are using either cloud-based with an iPad, so they're using mobile EHRs in that way. And essentially it doesn't, from a meaningful use perspective, differ very radically from what you would have with a terminal-based EHR.
So Rob, for the Medicaid program, will EPs who attest to AIU for the first payment also have 2 years of stage 1 before moving to stage 2?
Yeah, you essentially get, on the Medicaid side, you get a stage 1, or I'm sorry, you get a first year where you can receive an adopt, implement, upgrade payment in lieu of doing meaningful use. And then you would move on to a 90-day stage 1 period, and then you would move on to a full year stage 1 period, and then you would move on to stage 2.
Let's see. I'm just scanning a few. That one's probably for Rob. Could you comment on the distribution of hospital attestation objective and quality metrics numbers to the greater public at the individual hospital level? I'm not sure if that's clear.
It's not clear, and I'm not sure that I could comment.
Okay.
I think
No
we're sticking to stage 2 here.
Okay. Let's see. Are exclusions no longer allowed for stage 1? We have 5 providers who have already attested with exclusions. Can they do this for 2013?
For 2013, they can. But moving forward, it's going to be a menu set exclusion where they won't be able to. Okay. You're going to have to be able to show that you can meet, that you don't meet other menus objectives. You would be able to exclude from the others. Okay.
So to clarify, the first year an eligible provider is in stage 2, they only need to report a 3-month period and not the entire year. Is that correct?
I'm sorry, could you repeat that question?
Sure. The question is, the first year an eligible provider is in stage 2, do they need to report a 3-month period or a full year period?
It is, in general, the way that it will work is this. The only 3-month period that you would have, or the only 90-day period you would have, is your first year. The exception to this is for 2014. So everybody in 2014, regardless of their stage of meaningful use, is going to have a 3-month period on the Medicare side, a 90-day period on the Medicaid side, and that is simply because it has nothing to do with stage 2. It is because everybody will be upgrading to that 2014 certified technology at the same time. So if you are one of the people who has been an early attester, then you may be lucky enough to get your first year at stage 2 as a 3-month reporting period. But otherwise, for all other years, that first year and all years are going to be a full year calendar or fiscal, depending on whether you're an EP or hospital.
Is the batching for eligible providers in groups for state Medicaid attestation sites optional?
I'm sorry, batching for groups for state Medicaid?
Right.
You know, there isn't a requirement to implement that. It will be up to each state Medicaid agency about how they're going to handle it. The batch option, I should have been clearer about this, is specifically a batch option to upload your attestation to the Medicare system.
So for Medicaid, it's state-specific?
It is state-specific, yes.
Okay, great. Does the definition of lab results to be incorporated, yes, no, and numeric, apply to both stage 1 and stage 2?
I believe that it does. I'd have to go back and take a look at our specific breakout for that. The best thing at this point in time is to go and take a look at that final rule. I haven't had a chance to look specifically on what we break out as the structured format of that.
Okay. Can you define or clarify the difference between a transition of care versus a referral?
You know, we get this question throughout stage 1. I think that if you go back and you take a look at this rule, you're going to see in the comment section that we do clarify what we mean as far as transition of care, and it really is anything that is moving to a different site of care or provider of care. For a lot of people, a transition of care and a referral may very much overlap. We don't necessarily break it out that way. We're really focused on any time that you are transitioning a patient's care from one provider to another or one site to another.
Does the immunization measure still have an exclusion if incompatible HL7 version between EHR and immunization registry?
Yeah, if you take a look at it, it's still fairly broad. If you're not, if there's a reason that you are not able to submit to that registry, we do define it a little bit more tightly as to what requirements you'll actually have to be able to, what you'll have to be able to do to show that you submitted to the agency. So it may not be as simple for stage 2 as checking off the box and attestation, but there are still exclusions for it provided.
For CPOE, is it actually 3 reports in one measure to include medications, laboratory, and radiology?
It's a combination of all of those, yes. Okay. We did broaden for stage 2 beyond just medication orders to lab and radiology as well.
And they each have different thresholds that they need to achieve, essentially.
So they're asking whether the average of all of those 3, or I think we'll probably issue a little bit more of an FAQ to break it out. We do address this somewhat in the final, and I believe that we came down as a individual for each, but I will have to take a look at it to be certain. I'm sorry, I'm not able to give you a direct answer on that.
And then there was a follow-up question, sort of breaking out laboratory. Are all lab disciplines and radiology modalities included? So they use examples, lab, micro for lab, and then diagnostic, et cetera, for radiology?
Again, I would have to take a look at the specific section.
Okay.
To get that weedy, folks, you probably don't want to actually go to a webinar. You probably actually want to take a look at the final rule at this point.
Exactly. Okay, so let's see. There's another question about the 90-day reporting period. So can you clarify the 2014 90-day reporting period? Does that apply to EPs still in stage 1 or starting on stage 2?
So 2014 is a 3-month reporting period keyed to the quarters for Medicare EPs regardless of their stage. So both EPs in both stage 1 or stage 2. It's a 90-day period that is not keyed to the quarters on the Medicaid side, and again, for stage 1 or stage 2.
When recording demographics and vital signs, must this be done for 80% of all patients or 80% of patients whose records are maintained in the EHR? This references, I guess, your slide 18.
It's 80% of all patients, although the denominator can be limited to the sites with certified EHR technology.
Okay. I'm sort of reading these questions as we go. So let's see. Can you comment at all on the implementation date for early adopters of the CMS quality measures? Is the plan to have us always implement the changes to the logic or updates to MedLists at the end of a reporting period between 2 reporting periods?
So update to the specifications specifically, I think that you're going to get a little bit more guidance about that when we post new information to the website. and when we post information about updates for 2013 to those specs. We'll have a little bit more posted specifically for what you'll need to do in order to meet those.
Can you offer any clarification for the 50% requirement of outpatient encounters? Does outpatient actually mean non-inpatient / emergency room?
Yes, that's exactly what it means. And this is not a change in any of the policy at all from Stage 1. That stays the same as what you saw in Stage 1. So essentially what you would do as an EP is you would look at all locations outside of the inpatient, POS 21, or emergency department of a hospital, POS 23, and then you would have to have certified EHR technology available to you in at least 50% for locations that for 50% of those patient encounters.
Rob, do you have any idea when the final CQMs with eSpecs will be posted?
We don't have a firm date on it. I think that I heard that they were shooting for sometime in October, but I couldn't tell you anything firm. I do know that they want to try and get that out there as soon as possible because we know that there are vendors that are going to be developing those as part of their Stage 2 or their 2014 software.
Will aggregate reporting for eligible providers under meaningful use satisfy PQRS reporting requirements?
No. If you want to satisfy PQRS reporting requirements and EHR at the same time, you have to report through one of the PQRS reporting methods. You have to either report through that individual or that group reporting option.
If we reported Stage 1, if we attested to Stage 1 in the first year, meaning this year, and next year, well, let's see. So the question I think really is, will the providers need to receive a payment for year 2 under the redefined Stage 1 requirements? So if we already attested to, the first year, and then what do we do in year 2? Is it under the redefined Stage 1?
So if you did Stage 1 this year, let's say this was your first year, and then you move into 2013 as your second year, most of those changes to Stage 1 for 2013 are optional. So you could, if you wanted to use those new methods, use those. The only thing that is definitely going to take effect for 2013 is the elimination of the exchange of key clinical information objective. So that's really the only thing that definitely has to change. The rest of it is optional. If you started and did your first year of Stage 1 meaningful use in 2013, then Stage 1 in 2014, many of those are going to be required changes, and you would have to take a look at those. You would have to do Stage 1 under the new requirements.
For the patient access requirement, you mentioned that 5% must view, download, and transmit health information. What does transmit mean? Does this mean electronically to an outside institution, or what does transmit in that?
It is transmitting to a provider or exchange. There will be a built-in functionality to that certified EHR that allows it to transmit that information. The idea here really to encourage patients to be able to access their own health information and then download it for their own use or send it to another provider or so on.
How does hardship relate to pathology, anesthesiology, et cetera, and what does that exception mean for CQMs related to those services?
Well, as far as the EHR incentive program and meaningful use are concerned, pathologists, radiologists, and anesthesiologists will, if they have their specialties correctly indicated in PACOS prior to the payment adjustment year, they will automatically receive that hardship exception. That means they will not have to be meaningful users. They will not be subject to that payment adjustment. And since the reporting of clinical quality measures under the EHR incentive program is about achieving meaningful use, they would not have to report that for the EHR incentive program. Now, that doesn't necessarily exempt them from reporting clinical quality measures if there are other clinical or if there are other quality measure programs that they take part in, but for the EHR incentive program, it means they wouldn't have to report anything.
Will there be another opportunity in 2013 or later where CMS will solicit public comments on the EHR incentive programs? There are a few other hardship exemptions that CMS might want to consider, so additional providers can, if nothing else, avoid the penalties in 2015.
No, I'm afraid that the public comment period is part of the regulatory process, and we published a proposed rule, took public comments for a 60 or 90-day period, and then we used those public comments and what we had learned so far about the program to make some policy determinations. So that is set in regulation, and anything else would be another regulatory change, which would mean that we'd have to kind of go back to the drawing board. Likely the next time that we go through a public comment process is when we actually put out a proposed Stage 3 rule, and people can solicit comments based on what's in there.
If our hospital reports by July 1, 2014, will we receive payment adjustments?
No, that's the deadline. If you are a first-time meaningful user as a hospital in 2014, you have to, by July 1st, 2014, submit your attestation to CMS in order to avoid that payment adjustment. So if you hit that July 1st, 2014 for your first 90 days meaningful use, and you were successful with meaningful use, that's how you would avoid that payment adjustment.
For specialty eligible providers that are exempt due to hardship, such as anesthesiology, like you just said, how long is the exemption?
It's an automatic exemption. So it's going to carry through as a exemption category throughout.
So there's a question about the summary of care to different EHR vendor. Does each physician in an organization need to do this, or can the organization send one on behalf of all of the physicians in the group?
That's a really good question, and I think that you're going to see that we're going to have some specification sheets on the objectives and some FAQs on the objectives that will come out. And similar to how they answered that question for things like exchange of key clinical information and public health objectives, we'll answer something similar for this specifically for transitions of care as well.
I'm just scanning these other questions. I think we've covered most of the themes. Let me. Does the reporting for imaging or radiology, I guess, need to be just a report, or does it need to be an image?
You mean the access to imaging results?
Well, I just read it as it is, so I think that's the question is, like, in order to get credit, let's say, for doing radiology exchange or radiology orders, do we need to just send a summary report, or does it need to be the actual image?
Oh, as far as entering it.
Yeah.
Remember, this is an order entry. It is not. It is not results. It is about order entry. So, entering medication orders, entering radiology orders, entering lab orders. That the measure of the CPOE is centered around ordering, not around the results.
Great. Okay,
I was
Rob.
worried, and one of the things I just want to clarify really quickly, if I can, Kate, is we did change the imaging access through the system for Stage 2. It is one of the menu objectives for both EPs and hospitals. And the reason that I was confused was because we did get a lot of comments where people wondered whether they had to actually provide images within the system. And I do want to clarify that for that menu objective, it is about access to that image. It can link you to another system altogether, it is not required for that image to actually live within the certified EHR.
All right, excellent. So Rob, I think we've hit on most of the questions. There are some others, but I think we've hit the major themes. So thank you so much. And I'd like to suggest that at this time we shift gears and we go to Steve's presentation.
All right, thanks a lot. You can hear me okay?
Yes, we hear you, Steve.
All right, good. So thanks everybody for hanging on to catch the second half of our tag team presentation. We are literally here all week, so please tune in again if you can't get enough of us. I'd also want to make a special thanks to everyone that commented on both our rules. I think I can speak on behalf of Rob and Travis, who I'll be presenting with later this week, to say that on the receiving end, it was interesting, important to see the evolution in the comments that we received, folks definitely understanding stage one and the policies that we included, and on both sides, and what they liked and what they didn't like, and suggestions in a greater and surprising level of specificity that was really helpful to us in reshaping our final rules. So hats off to you all that commented, and for those that didn't, just keep in mind that this is a real important part of the regulatory process and your participation, and very much encourage you to comment on other rules as well as the next time we go through rulemaking. Next slide, please. Okay, so in terms of major themes, which I think you probably have already heard through some of Rob's presentation, in the standards and certification criteria final rule, the 2014 edition final rule, I abbreviate S&CC 2014 edition. There are probably about 4 or 5 major themes that we try to carry throughout the entire regulation, and that is about enhancing standards-based exchange, promoting EHR technology safety and security, enabling greater patient engagement, and Rob, I think, has touched on a few of those in terms of how it translates from a meaningful use perspective, introducing greater transparency, and this is largely through the certification program, which we also made modifications through our regulatory process, and in areas where we could reduce regulatory burden in response to the President's executive order, as well as stakeholder comments that we've received since our rulemaking in 2010. We took a really hard look at what we could do to make things better all around, from a regulatory drafting standpoint to a regulatory compliance standpoint. Next slide, please. So one thing I did want to take a quick pause on, and I am just reflecting this as a point of clarification, as a way to help you wade through the hundreds of pages of preamble in the regulations that you've got now to chew on. And I did want to caution folks to be aware of the different but complementary scopes that our rules address. And so speaking of my rule perspective first, the standards and certification criteria rule is focused on technical aspects of things and really specifies the scope, specifies the capabilities that EHR technology must include, and how the technology must perform in order to be certified. It does not specify how EHR technology needs to be used. And so that's really where you kind of flip the script here and you look at what meaningful use says, and that focuses on provider behavior and the use of certified EHR technology in a meaningful manner. And so the requirements that Rob just covered specify the actions that eligible providers need to take in order to receive incentive payments. And so my one caution and the important takeaway as you read through the rules, maybe read through them a second time, is that if you try and interpret ONC's rule as a proxy for or through the lens of how EHR technology should or could be used, there's a high likelihood that you could interpret ONC's rule incorrectly in applying it to meaningful use. And just to give you a couple quick examples, there are areas where for certification, we go through our separate authority, we require that EHR technology be capable of doing more things than may necessarily be the minimum that needed for a provider to accomplish meaningful use. And so for view, download, and transmit to a third party, that's an example where we require certain transport standards for certification. Meaningful use for this objective does not express a limitation then only that transport standard be used. And so EHR technology, post-certification, in implementation, could be implemented in such a way that transmission to a third party could occur through a variety of different mechanisms that are beyond the scope of certification in that case. And so if you had read and applied our regulatory requirements for EHR technology certification to how providers would need to meet meaningful use, then you would potentially interpret the meaningful use rules incorrectly. The other would be the patient education specific materials in terms of using certified EHR technology to identify education materials. We've included both a standards-based way and just more of a general functional-based way. And for the standards-based way, we've adopted the HL7 for shorthand info button standard. Context-aware knowledge retrieval, I think, is most of that standard specification's name. On the meaningful use side, again, meaningful use doesn't limit the demonstration or use of certified EHR technology to just the standard. And so in that case, you could misinterpret our rule. Next slide, please. Okay, so for those of you that caught a lot of the proposed rule presentations that I've given, I'm going to use some of the slides that I previously had in my slide deck from March, and I've updated them and kind of slid things over to be NPRM versus final as opposed to final rule from 2010 to NPRM last spring. So what we have here is a side-by-side in terms of the 2014 edition NPRM versus the 2014 edition final rule. In a couple of other slides, I'll just give you some designations here. Tried to use green and red in terms of ups and downs and in terms of quantity of certification criteria. Not too much just changed here. And so I think, as you've heard both from Rob's perspective and from Dr. Moshashari as he's discussed, we've pretty much stayed the course in our proposals. We have made a lot of clarifying changes and other tweaks within the certification criteria to make things better. But that's I just wanted to give folks a context and some semblance around what it is at a high level that the rules look like. Next slide, please. So we have three categories of certification criteria, new, as this slide connotes, and then the next two that follow are the revised and the unchanged. And so for the new certification criteria, we previously had this slide in my slide deck. We removed one certification criterion, that's the struck one on this slide, and then we have included two new certification criteria formalized in regulation text that we had solicited public comment on as a proposed criterion in our NPRM. I'm not going to go deep into each of these. There's a lot to cover, and so keeping this in terms of an overview and leaving some time for questions, I would, as Rob encouraged, to read through the preamble of our rules, where we've tried to do a very thorough job at addressing both public comments and providing additional clarity. And you'll find hopefully everything or most that you want to know about each of these certification criteria. These the ones that are new here correlate really with, in most cases, with the Stage 2 objectives and measures and some of the other conforming changes that were made to Stage 1. We can go to the next slide. So these are revised certification criteria. Many of these, all of these existed in some form or another in our 2011 edition certification criteria from our prior final rule, and we've updated them in some form or another, either adopting a new implementation specification, standard, vocabulary, expressing a slightly different capability, expanding a capability to make these certification criteria revised. And EHR technology, in order to be certified to the 2014 edition certification criteria, will need to meet these revised certification criteria. Next slide, please. So the one thing, and you'll have to keep in mind the prior slide that you just saw in terms of revised certification criteria, we have a select grouping here of unchanged certification criteria. And the reason why these unchanged ones are important is because there are what would be what's called eligible for gap certification for EHR technology developers, and that EHR technology developers through the 2014 edition certification process will be able to use previously issued test results for these certification criteria that remain in black and bold to count towards their EHR Technologies 2014 edition certification. The ones that are struck that include this kind of yellowy orange color it will have been moved into the revised table, the prior slide. And as you go through the final rule, you'll see that we've made, in some cases, tweaks in response to public comment that we felt necessitated moving these certification criteria into the revised category and having them be recertified. In some cases, very minimal changes, but for which we felt certification would be necessary, and others we've done some other modifications. Next slide, please. Okay, so the real crown jewel of our rule and its linkage and its relationship to meaningful use is the definition of certified EHR technology. And I always like to emphasize that it's capital C, EHR, T, capital T technology as a proper noun, as a term of art in our regulatory text. And it's meant to convey, and if you see the use of certified EHR technology, or as we've abbreviated it here, CEHRT, it's meant to convey a specific meaning. And as you can see on the slide here, the final rule policy in our 2010 final rule was really a static definition for certified EHR technology. And it was driven by the certification criteria that we adopted. And so in order to meet this definition, you needed to have EHR technology for the applicable setting, either ambulatory or inpatient, that had been certified to all of the certification criteria that we adopted. And what we did in response to public comment and stakeholder feedback in advance of the NPRM and our review of the potential regulatory efficiencies and burden reductions that we can include, we proposed a more dynamic definition that would be driven by meaningful use and driven by the stage of meaningful use that a provider would seek to meet. And so really what the difference here, and you'll hear me touch on it in a number of different slides that follow, is the quantity of EHR technology certified to the 2014 edition certification criteria that is going to make a difference in the future as we progress going forward. So just to summarize for folks, EHR technology that was certified currently today is good through 2013. If you have EHR technology that's a complete EHR or something that's been certified, that meets the current definition, free to continue to use that. I've got another slide that kind of lays this out as well. And this is the current definition as it stands is available and effective through 2013. We have included two other pathways in response to public comment, as well as predicting that there would be some transition period during 2013 in preparation to have EHR technology certified to the 2014 edition certification criteria by the time a provider starts their 2014 EHR reporting period. So one of the other flexibilities in the current definition is that folks can use a mix of 2011 edition and 2014 edition, so long as it continues to meet this static definition. The other flexibility is that in response to public comments, we said, and this is really the bottom text here next to the right corner of the slide, as soon as the final rule is effective, which will be pretty soon in October, and then EHR technology is certified to the 2014 edition EHR certification criteria, is available. It would be the provider's option, especially those who had not yet attempted to meet meaningful use, to jump right to 2014 edition EHR technology and meet stage 1 in 2013 using the 2014 edition certified EHR technology, as well as the flexibility in the amount of and the quantity of EHR technology certified to the 2014 edition that they would need to have. I think I've exhausted this slide. Next slide, please. So you'll see throughout a number of my slides, I joked around the other day that I spend half my time thinking in images and half my time writing. So a lot of the slides that I've put together here are a mix of words and images to try and give folks who process things differently two different ways to understand and learn about the changes that we've made to the certified EHR technology definition. As I kidded when I was presenting on the NPRM, if we get asked, how do you know if you've met the 2014 edition definition for certified EHR technology? and I'm going to reply it's as easy as 1, 2, 3 plus C, with C being CQMs. And as Rob mentioned, there isn't a stage distinction between CQMs, and so we've got a pretty good alignment between 2014 edition certification requirements and the 2014 basis for clinical quality measures. Some of these slides I'm going to jump over pretty quickly after I get through some of the initial ones, and I'll note to them that I've included them in my slide deck as a preview, as a reference, as for your information. There are other versions of some of these images on our website that I have a link to later in terms of my public service announcements here midstream. So one of the important concepts that we touched on in the proposed rule was this concept of the base EHR definition. And this is really the fundamental set of EHR technology capabilities certified to the 2014 edition certification criteria that would be universally applicable to all eligible professionals and eligible hospitals and critical access hospitals. And really the starting point at which they would begin to determine whether or not they have the right quantity of 2014 EHR technology to meet the overall certified EHR technology definition. So first, everyone starts their analysis at the base EHR definition, and then based on the stage of meaningful use that you would seek to meet and the menu, the core and menu objectives that you would seek to meet for that stage, including some of the exclusions, those are all factors that go into this new definition that would be driven by meaningful use. So one other point that I would raise in terms of the interesting regulatory balance and focus that we have to have is that our definition of certified EHR technology really speaks to two different audiences. It speaks to eligible providers on the meaningful use side in that context in terms of the EHR technology certified to the EHR certification criteria that we've adopted that providers would need to have to demonstrate meaningful use of. And it also speaks to EHR technology developers who will be looking at the meaningful use objectives and measures, and the ones that their customers generally have sought to meet now at this point through meaningful use, the ones that they believe will be potential to meet meaningful use, and being able to really, I think, have a more dynamic approach to the EHR technology that will be available for different providers to pick from going forward, whereas the prior definition, I think, created a little bit of tension in the market relative to the being driven by certification criteria. It led to some choices that would make it harder for certain specialties that could meet the exclusions and other types of policies that were including meaningful use. And so we've tried to balance that flexibility in both sides with respect to the definition of certified EHR technology as we've included in 2014. So we think from a burden reduction and efficiency standpoint that this is going to have a significant improvement on everybody's life. Next slide, please. Okay. So if it's important, it's worth saying 3 times, right? So the most important point, again, with the revised definition of certified EHR technology is quantity, quantity, and quantity, and keeping that in mind. And so it's all about the quantity of EHR technology certified to the 2014 edition certification criteria for the meaningful use stage that the provider, from the provider's perspective, that they would seek to meet. On the flip side, as I alluded to in terms of the 2 audiences that we speak to, this new definition that's driven by meaningful use and will hopefully be able to accommodate different stages of meaningful use and the different quantity of EHR technology that is necessary for certain providers to meet meaningful use, really, I think, gives EHR technology developers the opportunity to rethink the software packages that they made available during the 2011 edition and pursue other mechanisms through certification to get what I like to call right-size certifications for their customers. And while the certifications that EHR technology developers may seek for their EHR software may not be a one-for-one match exactly with provider A versus provider B. There may be a capability or 2 or 3 that the EHR technology developer has just included for certification in their kind of default standard issued product, but compared to the environment in which there would be significantly more capabilities than a provider would necessarily need to meet, say, for meaningful use stage 1. From a quantity perspective, this offers the opportunity for EHR technology developers to really work with our regulatory framework and to make available right-sized certifications going forward. So I think I've touched on a point that I wrote to myself in terms of what I wanted to emphasize there. I will go to the next slide. All right. So what, right? That's the question you've probably been asking as I've been talking. Why should you be excited? Why should I be excited? The big difference here, and you know, we'll have to see how it plays out in terms of, I have my own predictions, but there are now 3 ways to meet the definition for certified EHR technology. And so just to ground you in the 2 ways that previously existed, it was either a complete EHR certification or a combination of EHR modules that were certified, and that combination addressed an equivalent number of certification criteria to a complete EHR. And so at the end of the day, you needed to have 100%. The difference here now, as I've got with my little clip art here, is that a single EHR module could be certified to the requisite quantity of certification criteria that an eligible provider would need in order to meet either stage 1 or stage 2. And that's going to be a real big difference. And I think, you know, as it's noted here on the slide, the complete EHR designation and certification still offers ultimate assurance in most cases for anyone that's going to seek to achieve stage 1 or stage 2. But in instances where, for both audiences, where you've got an EHR technology developer that has a particular client base that can definitively exclude something under meaningful use, this new policy that we've included in the rule releases regulatory burden on those EHR technology developers from seeking certification for those capabilities that would essentially just require them to do extra work to get certified. An example of that would be, you know, like immunization reporting for dentists. You know, that was one of the effects of our policy in the prior rule. Going forward now, if you're a dental EHR technology developer and there are certain meaningful use objectives and measures that your clients would be able to exclude as a matter of fact, then you wouldn't have to go through those development efforts to include those capabilities and get them certified, because you would be able to produce an EHR module that had all the capabilities certified to our 2014 edition certification criteria that your customers would need to meet meaningful use. And so, again, that really gets back to that concept of right-size certification that I've been trying to emphasize. Next slide. Okay, pictures, pictures, pictures. So I've used these little number bubbles here to give folks some time. You may need to read through this separately after I burn through it pretty quickly. What I wanted to do is emphasize that throughout our regulatory processes and our regulatory requirements, there are only two types of certifications that are issued. Either a complete EHR, which by definition means that it's EHR technology certified to all of the certification criteria for the applicable setting. And that complete EHR, so MAT number 2, that means that it would be able to support either meaningful use stage 1 or meaningful use stage 2 achievement. For number 3 here, and this is the red square, gets back to the example that I just discussed about an EHR module that's certified to just enough or a little bit more of the 2014 edition EHR technology certification criteria necessary to support a provider's achievement of meaningful use stage 1. And so the other thing to mention here, I'll jump down to number 5, is that everyone will need EHR technology that's certified to the base EHR definition, and I have a slide that covers this in a little bit more detail next. But that really is, as it expands out, the kind of scope of the different certifications issued. Can you go back 1 second? Thank you. And the coverage of the capabilities that would be addressed by each of those certifications. The one point, again, that I would also highlight here is bullet number 4, where I tried to show a progression, which is what this arrow is, between the two dashed rectangles, where you could have an EHR module certified to a quantity of 2014 edition less than something that would get an eligible provider across the finish line for meaningful use stage 1 or stage 2. But in the case of the outer square, this dashed outer square, that would be a case where you've got an EHR module certified that could cover a provider's meaningful use stage 1 and perhaps be a right-size certification for stage 2. And so, there's a lot of different flavors, approaches that are available for EHR technology developers to work with their customer bases to get certifications that really make sense from a business perspective. The one other last point that I would note that I want to make sure that folks keep themselves reminded about and grounded in is this box at the bottom left corner and the kind of surrounded shading box once you get past meaningful use stage 2. And I really should have made that underneath the whole thing, even to the left and the right and the bottom. Certification does not address all the capabilities that would be included in EHR technology. And so it's a real important point to remember that the certification criteria that we have adopted in our regulation and for which EHR technology needs to be presented for certification isn't the whole universe of capabilities that, as a provider, your EHR technology may include. And so it's important to keep in mind that there are things for which certification is required and for which a complete EHR certification would be issued or an EHR module certification would be issued, but those don't necessarily cover all of the other additional capabilities that an EHR technology developer may include in their EHR technology offering. Next slide, please. So this is a different look at understanding the quantity spectrum for the certified EHR technology definition. Again, at a baseline, everyone starts with the base EHR technology that has to be certified to the certification criteria that are in the base EHR definition. And then trying to show here with the different brackets, different EHR technology vendors that could produce and get EHR technology certifications with different quantities of EHR technology. And so the left side here to the dashed arrow represents complete EHRs. And so in the case of a complete EHR, it tracks with the highest stage of meaningful use and all of the capabilities for which certification criteria, mandatory certification criteria exist. And so if you're an eligible provider and you adopt 2014 edition complete EHR, you're going to have more than what you need to meet meaningful use stage 2 at the start. But if I think like the scenario that Rob Anthony mentioned, or in another scenario where you do stage 1 in 2013 and stage 1 in 2014, in 2015 you'd be at stage 2 and you'd have essentially everything that you'd need without any additional concern for upgrades and other types of 2014 edition EHR technology certifications. I'll just call up bullet 3 here and probably bullet 6, or in terms of the one thing I'll touch on, I think, in the next slide about the base EHR definition is that it's a definition and it's not meant to convey that there is such a thing as a single EHR technology called a base EHR. And you could have an instance where certain certification criteria that are included in the base EHR definition are addressed by 2 different vendors in terms of the EHR modules, in this case, that they would provide for. Again, say for bullet number 4 here, green bullet 4, this is to show more of a right-size certification approach where the dashed box at the top in the MU menu and as well as a smaller core represent the reduced burden on the EHR technology developer side for not having to get certified certain capabilities that their customer base can exclude, as well as a provider only needing to have EHR technology certified to that 2014 edition certification criteria that they're going to use to meet the MU menu for stage 1. Similar principle applies for slide, bullet 6, and just wanted to show some of these different variations. There's a wide spectrum, but wanted to ground folks in the concept of base EHR definition represents the quantity of EHR technology that everyone needs to have. After that, that's really where this dynamic definition of certified EHR technology kicks in. Next slide, please. Okay, so this is the base EHR definition covered. I'm going to tear through this pretty quickly now that I've alluded to some of the points. It's a definition meant to be treated like a checklist. So as the slide now indicates, the first 5 rows on the left side, in terms of text, are straight from the HITECH Act, straight from the statute. And so what we did in the proposed rule and what we've done in the final rule is to assign certification criteria to those statutory described capabilities. The statute didn't include a capacity for the privacy and security for short, and so we've included that as a base EHR definition requirement. And so for any provider that's going to be trying to meet meaningful use starting in 2014 and meeting this new definition using 2014 edition certification EHR technology, they will need to have capabilities certified for these certification criteria as a start, and then, depending on exclusions and the menu, that's where the variability again comes in. Next slide. So here's another table that shows the flexibilities that I mentioned when I originally showed the kind of first bullseye diagram. The one thing that's changed here is the additional flexibility that we've added in. This is number 2, highlighted in green, with respect to the stages of meaningful use, the EHR reporting periods that begin prior to fiscal year or calendar year 2014. Bullet 2 indicates the policy decision that we made to allow folks to jump immediately to the 2014 edition definition, essentially, the one to the right side, in meeting stage 1 during the 2012-2013 EHR reporting period. Next slide. So this is a 4-year reference. We have these available on our website. There's a hyperlink at the end. We've assigned, in this kind of bullseye diagram format, the certification criteria for the eligible provider, either EH, CAH, or EP, and again, for the meaningful use stage that they seek to meet. So there are 4 of these available, I believe, in PowerPoint format, so you feel free to go on our website, download them, use them as you see fit. Next slide, please. This next one is one that we worked really hard to try and put together for folks, and I think really captures all of the talking head that I've just done on the definition itself for the past 15 minutes about the definition of certified EHR technology and whether you have what you need to meet the meaningful use stage that you seek to meet. And so it's an infographic style type decision tree model where if you adopt a complete EHR, that's pretty much all the calculus that you need to take into account. You can go directly to the meeting the certified EHR technology definition. In cases where you pursue a more dynamic route driven by meaningful use, then you got to go through these 3 steps essentially for confirming that you have EHR technology that meets the base EHR definition, and then there's a little bit of a split here depending on whether or not you're an EP or an eligible hospital in terms of the clinical quality measures that you need to have, as well as the objectives from the core and the menu. And so we hope that, again, this is a resource, you can go to the next slide as I'm talking, that we've made available, again, on our website for folks to download and use in their presentations as well. We also broke out, you've got the one that I previously showed was a kind of aggregate high-level bird's eye view, and then broke out into whether or not it's EP or critical access hospital, eligible hospital sides for the diagrams as well. So if you just talk to a particular community, then you can go and pull these slides for you to use. Next slide. So before I wrap things up, as I mentioned briefly in the beginning, we've made changes to the certification rules as well, the certification process rules as well. And if, for those of you that track our regulatory processes specifically, we had proposed and finalized a temporary certification program, which is currently up and running, and a permanent certification program. We have finalized in this final rule that the temporary certification program would sunset upon the effective date, which I believe is going to be October 4th. The change in the programs doesn't affect certifications that were issued to the 2011 edition certification criteria. Just the process by which any new certifications are performed have to go through the new process, the processes that we established as part of the what we're calling now the ONC HIT certification program. There are other revisions that we made, again, from a regulatory flexibility and burden perspective for EHR module certification that we think will have a better effect from a efficiency standpoint, as well as more innovative approaches in the EHR marketplace, and some other tweaks that are in the rule that I won't cover in any detail to make certification more efficient. Next slide, please. All right. So other changes that we've applied, there are certain new certification criteria that are prerequisites or requirements as EHR technology gets presented for certification. So this is more for EHR technology developers to pay attention to. There are the safety enhanced design, 8 medication-related certification criteria that we had proposed in our proposed rule related to user-centered design having being applied to those certification criteria. We also adopted as part of the final rule a certification criterion for the EHR technology developer to indicate the quality management system that was used in developing those capabilities for which certification is requested. And so to the 2 points about transparency, we require ONC-ACBs to look at 2 new things and to follow 2 new requirements in the process of issuing certifications. The first being that requiring that EHR technology developers notify through the notification and disclosure requirements that we already applied today, some additional information related to the types of costs that affect the certified complete EHR module's total cost of ownership for the purposes of achieving meaningful use. And so this is explained in greater detail in the final rule. The other point that we have finalized related to transparency is a proposal that we had made for the testing report card, essentially, that gets issued by the EHR Technology Testing Laboratory and that is subsequently used by the ONC authorized certification body as the basis of issuing a certification. Those test reports and the test results would need to be made publicly available, and the ONC ACBs are on the hook to require that and support that requirement. So those are 2 new things that folks should be on the lookout for. And we think will improve the overall rigor and transparency associated with the certification program. I believe the next few slides are for your reference again. I'll probably cover them in more detail when I present to the HIT Standards Committee later in September. And you guys, I think, can step through, whoever's driving, step through the next slides. Whoop, I think you stepped through them. Yeah, all right. So basically what we set up here, you can stick on this one. The applicability of certain standards as they've been adopted in the certification criteria, and how they break out in terms of vocabulary code sets, content exchange, and transport standard requirements. So again, those are for your reference shorthand. We can move to the next slide. Keep going. Keep going. All right. So what's next? Brief timeline. The final rule got issued. We have worked very hard to get the final rule out as soon as we did. Similar to the process that we followed the last time around with the 2010 final rule, waves of test procedures will be published, I think on a weekly basis for public comment. They will be, reviewed, refined, revised. At the same time, the temporary certification program will sunset, and later in the fall, later this year, the test procedures will be finalized, and then the certification machinery for 2014 edition certification will really start to get up and running. And I think the next slide that I've got is just our resources page. So make sure you check out this URL. It's got the meaningful use 2-0. If you go to the other one, I think it will just bring you to our NPRM webpage, so make sure you've got the 2.0 at the end of your URL. So right now we've got those the CEHRT infographic flows, the bullseye diagrams, a few other things that we took from the final rule as a 4-year reference related to the certification criteria for complete EHR. Other things that we have in the works are grids comparing meaningful use stage 1 requirements, objectives and measures, and 2 to our 2014 edition EHR certification criteria, similar to the grids that we had put out before, as well as a resource page where all of the adopted standards would be available and where you can go and find them. So those are things that we're working on. How to prioritize certain materials to get out right when the final rule came out, but you can expect to see more from us in the coming weeks. And I'm sorry for talking a little bit longer. Still working the kinks out of the efficiencies in the presentation, but happy to try and answer any questions I can at this point in time.
All right, Steve. Thank you. Excellent job. And we just have a few minutes left, so we'll roll through a few questions for you and then wrap it up. So a lot of people are asking, when will the vendors be able to certify for 2014 if the effective date of the final rule is early October 2012? Lots of people are asking that.
Sure. So, this is an evolving process, and I think it was anticipated that there would be a test procedure development and finalization period after the final rule, which is really why we had an intense effort to get our rule out along with CMS's as soon as possible for the industry. The final rule effective date, I don't think really has too much of an effect on the timeliness of things. That would be the soonest by which certification could occur. But as I understand, I mean, there will be a period of time where EHR technology developers need to sort through all the certification criteria, update their software through software development efforts, make sure that all the other changes and tweaks and things are debugged, and so all those things are going to take some time that I think we had expected, and the test procedures as well to make sure that they meet the testing requirements and are traceable to our certification criteria. So I don't have if I set a definitive date, I'd probably be I just wouldn't be able to. And I think everyone is fully committed to getting out test procedures and getting out any of the additional supportive materials as soon as possible. But this is something that's going to be evolving as the rule, since the rule is final now, and that it's not necessarily a moving target for all the test procedure development activities.
So, Steve, in order for an EHR vendor to secure 2014 edition certification, does that mean the technology needs to meet Stage 1 and Stage 2 base EHR definition, core, and menu objectives?
So let me see if I can approach this a little bit differently. I would encourage you not to think about certification through meaningful use stages, because the certification criteria are agnostic to the stages. If an EHR technology developer wanted to make available a product that would that a provider could use to meet either Stage 1 or Stage 2, certified to the 2014 edition certification criteria, right out of the gate, it would need to have all the capabilities specified in the base EHR definition, as well as those the EHR technology developer anticipated that its clientele or its customers would use to meet, and this is where a kind of quantity decision fits in, to meet Stage 1, which would be a limited quantity, less than Stage 2, and you could get an EHR module certified to that quantity for folks that were meeting Stage 1, and you could get another EHR module certification that would be supportive of the additional capabilities that folks would need to meet Stage 2.
So if we can go back to your slide 86, the question is, can you clarify the context of the word quantity on this slide? When you say that the EHR module is certified to quantity of 2014 edition, do you mean that it is certified to some of the 2014 edition criteria, or is some other definition of the word quantity being used here?
Sure. I didn't expect that word to be parsed, but I'm happy to answer it. So, anytime I talk about quantity, I don't remember the number offhand, but say that, for argument's sake, there are 50 certification criteria, and when I talk about quantity, it is of the 2014 edition, there could be an EHR module certified to, say, 35, let's say for Stage 1, 35 certification criteria in the 2014 edition that would cover and correlate with the requisite meaningful use objectives for Stage 1. And so that would be like bubble number 3 here, where you've got an EHR module that's certified to whatever the number is to cross that threshold, that it covers the base EHR definition plus the requisite core that an EHR technology developer's customers would need to meet, plus the capabilities, the certification criteria that would be expected or available for their customers to meet in the MU menu. So when I talk about quantity, that's what I talk about in terms of the distinctions. Whereas, again, using 50 as an arbitrary number, a complete EHR would be certified to a quantity of 50 certification criteria, whereas the module, for the Red Square would be certified to 35 in terms of a quantity of 2014 edition certification criteria.
All right, Steve, thank you. And we're going to have to bring the program to a close. So thank you so much, Steve. Awesome job. And I'd also like to thank Rob Anthony for a very informative presentation. Thanks, everyone, for joining us today. And as you exit the webinar, we're going to just pop up a very short survey for you to complete. And we really would appreciate it if you take a moment to do so.